Good evening, everyone, and welcome to Mahamana Case Discussion Series. And we are very pleased to welcome you all as this is our second anniversary and we have completed 2 successful years of this teaching program. And this teaching program was started aiming that all the specialists and all the residents at any given point of time are not simultaneously exposed to what the philosophy of the masters across the world is. And with that intention, we brought together all the stalwarts. We asked them to chip in, make their comments, and also ask the residents to come forward and make their presentations so that they're able to interact. And we are very glad that Mahamana could have this platform for all of you. For our second anniversary session, we have invited Dr. Anil Dikru sir, although he does not need any introduction to this crowd, but he's the director of oncology of Apollo Hospitals, Delhi, Mumbai, and Chennai. He is the ex-president of UICC.
President Ankur.
And I would request Anil Dikru sir, and he will be speaking on evolution of the management of the neck. Sir, you may please share your screen.
Thank you very much for having me on this second anniversary show. Congratulations to you, your entire team, Komal, your other staff. Teaching has always been dear to my heart, and I've followed the progress of your case series over the last 2 years. And I just think the students of today are just so lucky to have these kind of online teaching modules, as you rightly said, from the masters in the field. I hope I was born in a different era and I could participate in the Mahamana series as well as a student. Probably I would have been a better head and neck surgeon. Now with such a plethora of meetings and so much of knowledge that you can get at the drop of your hand. Today I'm going to speak on the evolution in the management of the neck. I have 30 minutes. I'm not sure I'll be able to finish, but I'll be happy to stop anytime in between. If I finish earlier, we can do a little bit of questions and answers. Now, most talks on neck nodes start with this slide that it's the single most important prognostic factor. The two important prognostic factors in head and neck are distant metastasis and cervical lymph nodes. Distant metastasis you can do nothing about. Cervical metastasis you can do nothing about, but you can treat correctly. And management is very important to improve survival. The moment you have a small spot in the lymph node, it becomes stage 3. Survival drops to 50%. If it comes out of the capsule, and it can come out of the capsule even in nodes less than a centimeter, further reduction in by 50%. So we must manage the neck very, very appropriately. Realizing this, when I was at the Tata Memorial Hospital, me and the entire faculty, one of the areas of focus of what we did was management of the neck. And I must say, we have had a lot of publications, many of them seminal, many of them that have changed the way the neck is treated, not only in our country, but even overseas. I'll share some of the data with you and some others you all can follow in the literature. Suffice to say, can people please mute their mic? There's some people with their mics on, which is a little disturbing. Can I please request everybody attending to mute their mics? Suffice to say that many of the studies that we did today form the basis of international guidelines. We all write publications, but I'm telling many of the youngsters who are listening to us today, please focus on publications that will have an impact either in your country or have impact internationally. And to me, international publications are the way all of y'all should go, that impact on change in guidelines. And that's why we have had pride of place to be part of the ASCO guidelines, as well as pride of place to be part of the European guidelines. Now, what has happened in the management of neck? What is the evolution that has happened? In the last century, a lot has happened. We've understood the biology of metastatic disease better. There have been a lot of advances in technology, imaging, the sentinel node biopsy, advances in pathology, immunohistochemistry. We've appreciated the functional aspect and the importance of quality of life of our patients. But most importantly, the emergence of a lot of new data. So the two bullets that I've put in red really have caused a paradigm shift in the way we treat the neck, a better understanding of the biology and the emergence of new data. And as I go along, I'll try to make you understand the importance of these 2 points. Again, my second message to y'all. So make an impact internationally, make an impact to change guidelines, but do it with studies that understand the biology of disease as well as solid new data. Most of us go for advances in technology, but that may not be what y'all as youngsters need to do. Now, the neck has evolved from 1800s, 1880 to be precise, all the way to 2015 when our publication came, and even further beyond. I cannot finish all this in half an hour, but I'm going to pick up salient aspects. But for those of y'all who might miss the rest of the presentation, please remember that the neck has evolved from very, very radical surgery to more conservative surgery, and then now into the newer technologies and what the future will hold. And that in brief will be the nutshell of what I'm going to present. Since it's evolution and I love history, y'all must listen to a few important things on how the neck is treated. In the early 19th century, people understood that cancer of the cervical nodes is important. There were four giants in Europe who operated: Langenbach, Billroth, Volkmann, and Kocher. All of them excised metastatic lymph node masses, encompassing surrounding uninvolved structures and tissues. The excision of single lymph nodes was the norm. But as you would know, and we understand now, there was absolutely no benefit to the patient, often with disastrous results. Imagine excising just an N3 node. So early 19th century, the way they treated the neck was not good. But towards the end of the 19th century, and this name never comes up in presentations, Henry Butlin, he's the father of head and neck surgery in Britain, in 1885 proposed the concept of comprehensive neck dissection. Those days it was called prophylactic neck dissection. He did a kind of a compartmental excision and showed that if you excise the primary with the neck, patients survived longer than if you only took out the primary. So here was born the concept of doing a neck dissection in a compartmentalized fashion, but it was not truly an entire full neck dissection. And all of us give credit to George W. Kreil, who published in 1905/1906. For those of you all going for exams, 1906 is taken as Kreil's publication, but that's because it published in JAMA, which is a very well-known journal. But he first published in 1905. He had 12 patients less than what he published in 1906, but that was in a local journal. So if the examiner troubles you between 1905 and 1906, that's a little bit of trivia. There was nothing heard about this thing till Hayes Martin's popularized it in 1951. Again, Hayes Martin was the chief of the Memorial Sloan Kettering, and wrote an article which is about 50 pages and published in Cancer on radical neck dissection. But truly, the first radical neck dissection was reported by a Polish surgeon called Jałdecki, and it was reported in 1888. He only reported one case. The patient lived for 7 years. We didn't hear much about this surgeon later on the neck because unfortunately he died at the age of 45. So the third message to y'all today, youngsters, I'm just going to keep stimulating y'all. Jałdecki wrote about the radical neck dissection, but he published in a Polish journal. People didn't know about it, and George Kreil got all the credit. So if you all have a good idea, publish in good journals and do not just sit back and say, this is my idea, present in conferences. People will not take note of you. Now, for most part of the 20th century, after George Kreil's 1906 description, radical neck dissection was the norm. This is how a neck look. We remove the internal jugular vein, we remove the accessory, we remove the sternocleidomastoid. Please, madam, it's unkind for you not to mute your mic. Asim, can you just see who it is and just ask them to stop muting?
I'll request everyone to please mute their mic once they join.
So this is what a radical neck dissection specimen looked like. You had the carotid, you had the hypoglossal, and the rest of the neck was absolutely bare. You can see the posterior triangle. 1906 to 1990 approximately, and here's a seminal article by Professor Jatin Shah in the American Journal of Surgery, 1990. 1,119 radical neck dissections from 1965 to 1986. 33.3% of these were done as elective for micrometastasis, obviously an overkill to how we understand the biology of the disease today. So for most part of the 20th century, the radical neck dissection was the standard of care for patients. And here I'm showing you all the way up to 1986, published in 1990 in a premier institution, they were doing the radical neck dissection. But people realized that it was too morbid a procedure. This is what patients look like. Atrophy of the trapezius, a subluxation of the sternoclavicular joint, and a useless arm. 82% of patients had pain in the neck, upper back, and occasionally in the arm. There was diminished strength when performing regular daily activities, something like just placing dishes in the overhead shelf or putting your luggage in an aircraft upper compartment. Schoen and Yardley, in a very classical presentation, show that 46% of patients after a radical neck dissection had to change their occupation if they were workers. Here is another message to youngsters. Be careful in the region of the accessory nerve. We treat a lot of poor patients. We are sometimes casual near the accessory nerve. 46% of your patients will have to change their occupation if you're not qualified to save that accessory nerve. And as I go along, I'll show you how this evolved on the accessory nerve. But just to drive a point home, we tend to get casual when we do level 5, level 2B. Please place your mind very carefully and be gentle in the region of the accessory nerve. I told you that the radical neck was done till the 80s and 90s, but around the 60s and 70s, there were people who recognized you do not have to remove all these structures. The first man to do that was Osvaldo Suarez, Spanish guy, 1963. He realized this in the late 50s, published in a Spanish journal, where he showed that dissection of the spatial space with removal of the contained lymphatic system was good. You didn't have to remove all the nerve, muscle, and vein. Subsequently, Boca, Javelin, and Jesse in their publications, revived this concept of a modified neck dissection, stroke functional neck dissection. They showed that a conservative neck dissection can be performed even in the presence of palpable lymph nodes, provided they were not fixed to other structures. So here was born the concept of doing the modified neck dissection in the 60s and 70s. People recognized you don't have to remove the structures and cripple your patients. Again, for the youngsters, please note the names that I quote. You can Google, read these articles, they're all seminal. Literature is replete with a lot of articles, but I've just chosen those that cause the paradigm shift. From the 80s onwards, therefore, studies came. Boca studies came, published in Laryngoscope, 843 patients. Byers from the MD Anderson, 1985, 967 cases. Anderson from the MSKCC, 1994, American Journal of Surgery, 336 patients. They looked at R&D, they looked at modified radical R&D, saving structures, 5-year survival, and look at the neck failure rates. Absolutely no difference statistically, not significant. They showed that M&D is equal to R&D, but the morbidity is much less. And that's how we started doing the mRND or the modified neck dissection from the 1980s onwards. 3 large series showing that it was a safe procedure and you didn't have to do a radical neck dissection. Then our specimens started looking more like this. We started saving the muscle, we started saving the vein, we started saving the accessory nerve. But maybe we were dissecting this quite a lot, because to bear this accessory nerve in the posterior triangle, you still had 5 to 40% of patients who had shoulder dysfunction despite saving this nerve. Around the 70s and 80s, seminal publications, and I've only quoted 2. One is Lindbergh's article, and Lindbergh was from the MD Anderson, published in 1972. The distribution of cervical lymph nodes showing the patterns of metastasis. And again, youngsters, this is an article you all must read. And of course, Dr. Jatin Shah's article in 1990, looking at the patterns of cervical lymph node metastasis from squamous cancers of the upper aerodigestive tract. So what did these 2 articles do? It showed us, depending on the site of disease, you had metastasis to particular regions of the neck. So oral went from level 1 to 3. Larynx, oropharynx, hypopharynx went from level 2 to 4. The central compartment involved the thyroid and the glottis. So we knew that there is a risk of a particular subsite going to a particular region of the neck. And maybe we could just operate these regions of the neck. Again, literature is replete with this, but the only randomized trial many years back in 1998 came from the Brazilian head and neck group. Squamous carcinomas T2 to T4N0, 148 patients, looked at MND versus an SOHD. Recurrences statistically not significant. 5-year survival, exactly the same. But when you look at complication rates, if you did an SOHD, the complications were much less than an MND. Hospital stay was more or less the same. And here was born the concept that you need not do an MND which had replaced the RND. You could do just an SOHD, randomized evidence. There are a lot of studies, retrospective, prospectively collected, non-randomized, that show exactly the same findings. And I'm not going to spend my time to do that. But we move still further. the SOHD was only being used for the N0 for staging. We started finding from literature that even in a node positive, you could do just an SOHD. Here is a meta-analysis looking at 5 studies, 443 patients, published in 2015, looking at ipsilateral, contralateral, and overall neck recurrence. Look at the disease-specific death rates and the overall death rates. P-value not significant. It's not less than 0.05. So you could do selective neck dissection even for node positive patients. So we've moved from R&D to an MND to an SOHD or an SND for node negative. And now we've started doing SOHD for node positive patients where the p-value is not significant. Which cases can we do this for? The Alfeo-Ferlito group looked at PRISMA guidelines, meta-analysis, and a systematic review and meta-analysis, and only read the bottom of my slide. SND is a valid option in patients with CN1 and selected CN2 disease, that is clinically N1, and even for N2, provided these are non-fixed nodes, absence of palpable metastasis at level 4 and 5, or large volume greater than 3 centimeters, multiple lymph nodes at multiple levels. So we move now to doing a selective neck dissection, 1 to 3, even for diseases where the node could be positive. I've shown you one meta-analysis and I've shown you PRISMA guidelines collating all disease to show that this is a safe option. Because the accessory nerve is at risk at level 2B as well, you need not be very aggressive to level 2B. Again, in the interest of time, I'm not saying what is level 2B and other things. I'm sure the attendees understand all that. I'm just giving you all a flavor of how this science moved. So here again is a meta-analysis and systematic review looking at level 2B. 445 abstracts, 129 full text papers, 22 studies included in the analysis. They looked at 2001 patients. Level 2B is only positive in 112, that is 6% of patients. Of tongue cancers, 400 patients, the incidence was 7%. That means if you have tongue cancers, the incidence of level 2B is higher. And 2B always went together with 2A. Only 3 patients were found to have isolated 2B without involving the other levels of neck. So again, when you operate, don't be very aggressive at level 2B. You can do 1, 2A, 3. If you see their bulky nodes positive at other levels, you can be aggressive at 2B. Otherwise, treat the accessory very, very gentle. You don't have to take out every globular flat around level 2B in your dissection. So we've moved from radical neck dissection. We've come to SOHD, and we are not being aggressive at level 2B in the vast majority of patients. We switch gears from extended neck dissections coming down to smaller to whether we should operate the neck at all. And I put this up because it's pride of place for us within the country, because here our study has really impacted the way people treat this cancer. So should the clinico-radiological N0 neck be addressed? There's a 5-decade debate in this. There were 2 schools of thought: either wait and watch and do a therapeutic neck dissection, or do an elective neck dissection. So wait and watch people observed. If the patient got a neck node, they would operate. And they believe that if you just operated unnecessarily, it's an overkill in 70% of patients who will never develop a neck node. The elective neck dissection group said that if you do it electively when they N0, you have better control and survival, because when the patient comes back, they usually come with N2, N3, they need major surgery, radiotherapy, and they don't do well. So for 50 years, people continued to do the elective neck or the wait and watch. And I've just collated data from 1980, when the first randomized trial to address this was there, all the way to 2015, when our study answered this question. There were different types of studies: prospective, retrospective, meta-analysis, different endpoints. And as you can see, the conclusions of all were not significant, whatever the endpoint that you used. So people continue to treat the treatment differently till we decided to do this randomized trial. From 2004 to 2014, we screened 1,281 T1, T2, N0 patients, randomized 596. We analyzed 500, 243 were randomized to the elective neck dissection arm and 253 to the wait and watch. Simple study. Just look at early, put one group doing the neck, one group no neck at all, and see what the outcomes are. Here are the outcomes of our study. Elective neck dissection should be the standard of care for all cases with early stage node negative. One death is prevented for every 8 patients treated with elective neck dissection. And this is powered on a 12.5% difference in overall survival. One recurrence is prevented for every 4 patients treated with elective neck, and this is powered on a 23.6% difference in disease-free. And I'm showing for those of you all who are Puritans and want to see the statistical graphs, here it is. So if you did a neck dissection, the END arm, the failure rate was 69.5% as opposed to 45.9%. If you waited and watched and operated, definitely the death rate was much less, and you can see the hazard ratio and the p-value highly significant. Look at overall survival. There were 50 deaths in the elective neck dissection arm, 79 in the therapeutic neck dissection arm. Difference was 88 to 67.5, and look at the p-value again, highly significant. So doing the neck is very important. And I must tell all the youngsters that whenever you'll see an early oral cancer, operating on the neck is very important. Can be looked across the forest plot, and you can see the benefit is across all subsites, except in our study, if the depth was less than 3 millimeters. You can see this little small blue dot, which is very small, and it does not show a benefit. But this should be interpreted with caution. Our study was not powered to answer this question. If you look at the number of events and the number of patients, out of over 500 patients, there were only 70 odd patients with such thin tumors. And you are never able to know which tumors are less than 3 millimeters. So the only time I don't operate the neck in N0 is if a patient comes after a wide excision of the tongue and they have a DOI less than 3 millimeters on final histopathology and they seek my opinion, I tell them that you can be on follow-up rather than do the neck. But otherwise, if they came to me upfront and I'm not able to know the depth, I would always operate these patients and do a neck dissection. Subsequent to our study, there was a parallel study running in the UK known as the SEND study. Exactly the same design, T1, T2, N0 randomized to 2 arms. When our data got published, they stopped this study. They had done 250 randomized. The ethics committee stopped the study. So they published their data with 250 randomized and 346 observational cohort. Exactly the same finding as ours. You operate, you save lives. Subsequent to a second randomized trial, there have been 8 meta-analyses. And this slide is slightly old. There may be a 9th and a 10th as well, but I don't have much space to put more meta-analysis. But I've collated this on a chart. Look at the conclusions. Whatever the endpoint, whether it's overall survival, disease-free survival, look at the benefit of doing an elective neck dissection across all meta-analysis that look at randomized trials, that look at retrospective studies, look at prospective studies. You must operate the neck. So you've got 2 randomized trials and at least 8 to 10 meta-analysis showing that you must operate your patients. So now the neck is treated with selective neck dissection. It's a staging procedure for an N0 and for small volume node positive cases. But we still have patients who will have shoulder dysfunction. And as I told you, please do not be very aggressive at 2B, pulling on the accessory nerve to clear this fat behind in patients who don't have gross adenopathy at 2A or other levels of the neck. Whenever you do the neck, you must do the neck completely. Follow anatomical guidelines. You must have a minimum of 18 nodes harvested in your neck dissection. If you have done a good neck dissection and you do not have 18 nodes, please go to your pathologist and talk to them. And I've just put this study up of Vasu Divi, published in the JCO in 2016, NCDB database 2004 to 2013, looking at patients with less than 18 nodes as opposed to those more than 18 nodes. If you look at those with less than 18 nodes, they had more favorable characteristics. They had a lower proportion of T3 to T4 lesions. They had fewer patients who were positive node, and they had lower rates of ECS. But the outcomes in these patients were worse than those who you had harvested more than 18 nodes. So please ensure that you always harvest more than 18 nodes. And also ASCO have put it into their guidelines. If you operate a patient with more than 18 nodes, even if you have a single node positive, you need not give this patient post-operative radiotherapy. We can debate on that subsequently, but please ensure you have completeness of neck when you'll operate your patients. I quickly tried to take you through how the neck evolved from RND to MND to SOHD for N0 to SOHD for node positive. Where do you go from here? We know that 50 to 70% of our patients may not develop neck metastasis. Could we do something to identify these patients? Could we do something less than an SOHD? And here comes the sentinel node biopsy. Literature is again replete with publications over 2 decades showing that the diagnostic accuracy of a sentinel node is upwards of 90%. So it's a very good procedure. You just pick out one node. The breast and melanoma guys do it very, very often. But recently, in the last 5-7 years, the sentinel node biopsy got a recent fillip because of 2 randomized trials, one from Japan and one from France. The French trial is called the Gerel trial, and the Japanese trial is called the Hasegawa trial. So youngsters, again, you must know both these for your exam. Summary of both trials. Both trials showed that the safety of the SNB procedure. Both trials showed that shoulder function may be slightly better with the SNB. And shoulder function seemed to improve over time, was more or less similar at the end of 1 year. So the only advantage of doing a sentinel node was better shoulder function. And it seemed to be the same if you did a neck dissection or a sentinel node biopsy with time. So where does the sentinel node biopsy stand? A collation of the 3 meta-analyses on sentinel node biopsy exactly the same findings. The efficacy is the same as a neck dissection, but lower side effects predominantly related to shoulder dysfunction. But a sentinel node biopsy has a steep learning curve. It costs much more. It's a cumbersome procedure. You have to inject dye, you have to inject nuclear studies, you have to do serial step sectioning, you have to do IHC. If it comes positive, some of your patients will have a two-step procedure, and the morbidity becomes okay with time. It's not like limb where the breast, the hand swells a lot, and in our cases all the shoulder function returns to the same at the end of 12 months. So should we all do a sentinel node biopsy? In India, difficult. We all don't have the infrastructure to do it. The data is safe but not compelling. And look at the US, where they have fewer oral cancers than us. They're not pushed for time. They're not pushed for finances. Looking again at an NCDB database 2012 to 2015, sentinel node biopsy was better. But of 8,328 patients, only about 3% of patients had the sentinel node biopsy. So even in a developed economy as the US, as recent as 2019, very few patients are doing the sentinel node biopsy. So youngsters, you don't have to feel bad if some of your colleagues from major institutions brag about doing a sentinel node biopsy. You'll be safe with your patients if you operate and do a neck dissection and don't go very aggressive on level 2B. Times will change. It may become standard of care, but I've seen many a summer more than many of y'all. I'm not sure. It will be something like those who want to do it, do it. When patients demand it, do it. The others, some of us will continue to do the elective neck dissection. What else is changing in the neck? We are using better dyes. We are using indocyanine green. We are doing near infrared fluorescence, which helps us detect the sentinel node much better than having the blue dye and the gamma. So we are advancing in this. We will progress. The sentinel node may become much better, and we could be able to then use it into our practice. It's going further into artificial intelligence and deep learning. So here you have to do serial step sectioning. A pathologist takes a lot of time to see these slides. Maybe deep learning, artificial intelligence may be the answer, where it'll highlight which patients need to have a second stage surgery or maybe not. And this has been validated to upwards of 90% sensitivity in subjects such as breast cancer. Maybe we can use molecular profiling, gene expression profiling. And when I was at Tata's, we did a small cohort of 11 patients looking at miRNA transcriptome sequencing, trying to predict whether molecular signatures would predict lymph node metastasis. So maybe we'll just do this molecular profiling on our primary tumors, and you get certain signals which tell you this patient's not going to have metastasis. You can avoid the sentinel node biopsy as well. At present, many people have done this, but the sensitivity hovers between 70 and 80%. It doesn't go closer to 100%. But this is an area of research that we can do. And of course, a smaller procedure called the super selective neck dissection, where post-chemo radiotherapy, you just pick out the nodes that are at risk. And this is Katie Robbins' super selective concept, where they treated patients with intra-arterial chemotherapy, radiotherapy, and did a super selective. Maybe we will come to a time where we can then predict which patients are at maximum risk and do a super selective. This is not very applicable to oral cavity, but I put it up here because we are talking about the neck. And I just thought youngsters should know that there is a concept called super selective. The man who popularized it was Katie Robbins. And you all must know this because super selective is often a short node. A robot, no talk is complete without a robot, and robot is coming into neck dissection. Again, a meta-analysis showing 11 comparative studies of 225 robot versus 430 open neck dissections, both for squamous skin and thyroid. You can see that there's similar perioperative outcome. They require significantly more operative time, some superior cosmesis, but it's really a non-validated tool. So again, I'm not sure robot will come into frontline treatment in the management of neck. I know a few people in our country popularize it, few people in Korea do it, but the vast majority of head and neck surgeons the world over do not use the robot for the neck dissection. So I'm ending, and I think I'm on the dot of 30 minutes, that the neck dissection, modified and selective neck dissection, has replaced R&D in the treatment of neck disease. Generally, the M&D for large volume positive nodes, otherwise the SND is okay for the rest, both N0 and small volume neck disease. The role of sentinel node biopsy is evolving. It's important for you all to know there is no role for compromised surgery and residual disease. And R&D is indicated if structures are involved, and you must do a minimum of 18 nodes in all your dissection to ensure completeness of surgery and that you've not left back residual disease. So Asim, thanks once again for the pleasure of this half an hour. I can see the number of participants is a perfect 100. So I'm happy with looking at that. You've got such a large crowd that has come for your clinic and this little talk. If you permit and people want to ask questions, I'd be happy to do that. Otherwise, we can move on to the clinic. Sarath has asked that, would you do a salvage neck dissection? Would you do a MND or an SONG? Sarath, by and large, oral cavity cancers don't have salvage. They're treated upfront with surgery. But if a patient has recurred and I'm operating again in an operated field, I will do a completion neck. I may or may not operate the other side of the neck because the patient who gets a second primary has a chance of a third and fourth primary. Don't go gung-ho about operating the necks and compromising vasculature. We've operated patients once, twice, three times. You have to preserve as many vessels as possible. So the salvage in an oral cavity is dictated on a case-to-case basis. But you're correct, if it's an undissected neck and the patient comes with the disease, I'd probably do an MND because the majority present with stage 2 and 3 lymph nodes.
Sir, I have a question.
Yes, Asim.
So, sir, if in case there is a operated neck and no adjuvant radiation or no adjuvant treatment has been given, in those cases, in a recurrent local recurrent setting, when we are operating, and if there's an ipsilateral setting, do we go for a completion neck dissection of level 4 and 5?
I would say yes and no. If the imaging is absolutely normal, there is absolutely no reason for me to open 4 and 5. It depends on the recurrence as well. If it was a pure N0 and it has a regional recurrence, I would probably not go absolutely onto 4 and 5 to operate the neck. There's absolutely no proof. Once you violated the neck, the lymph nodes can go anywhere. They can go on to the opposite side. They can go on to the retropharynx. So I'm not sure there's any benefit to operate 4 and 5. Very often, the entire neck is plastered as well at level 4 and 5. But when I said yes and no, it's because when I open the neck and I'm searching for the vessels to give to my plastic for a free flap, usually 4 is opened. At that time, I will clear 4 and at least 5A in my dissection. But I'm not sure I know of any data that shows there's benefit to complete 4 and 5.
So we'll now proceed with the case presentation. We have, and I'd like to invite the examiners for the same. We have Dr. Anil Cruz sir with us. The first examiner is Dr. Deepak Balasubramanian. He is a professor of head and neck surgery at Amrita Institute of Medical Sciences, Kochi. Welcome, sir.
Thanks, Azim. I'm here.
Dr. Richa Vaish. She is professor of head neck oncology at Tata Memorial Hospital, Mumbai.
Hello, Asim. I'm there too.
Yeah. And Dr. Apurv Garg. He's a consultant head and neck surgeon at Visesh Jupiter Hospital, Indore. Welcome, Apurv.
Right. Thanks. Thanks for calling me. Yeah.
For the case presentation, we have Dr. Anthony Raj James. He is a MCH resident at Tata Memorial Hospital. And
Good evening,
good evening. And Dr. Kiran Joshi. She is a MCH resident at Amrita Institute of Medical Sciences, Kochi. So we'll start with the first case of Anthony and then finish with the Kiran's case presentation. And then the examiners can ask both the fellows together. Anthony, you can please share your screen.
Sir, is my screen visible, sir?
Yes.
Good evening to one not present here. So I'll be presenting a case of late-stage tongue cancer. So my case is a 34-year-old male.
Asim, let me just stop Anthony. Anthony, put your screen on. Let's see you.
Yes, sir.
Lovely. Even the examiners, please put your screens on. It's better. It becomes a little more personal. Apurva, put your screen. Richa and Deepak. Okay, lovely. Go ahead, Anthony.
Sir, it's a 34-year-old male, resident of Jalna, Maharashtra, a farmer by occupation, no comorbidities, no family history of cancer. He's a tobacco chewer daily for since 7 to 8 years and stopped since the last 1 month. So his chief complaints to us, he presented to our OPD with complaints of non-healing ulcer over the right lateral border of tongue since last 1 to 2 months, pain over the right side tongue, aggravated on chewing and swallowing since the last 1 month. So patient was apparently asymptomatic 2 months back when he noticed an ulcer on the right lateral border of tongue, which was insidious in onset, initially small in size, gradually progressed over a period of this 1 month to attain the present size. Patient is associated with pain, with aggravated on chewing and swallowing, and it is relieved on painkillers. There is history of foul smell from mouth, and there is history of occasional bleeding from the lesion. And there is also the history of difficulty in speech, chewing, and swallowing. And there is also worsening of pain while speech, chewing, and swallowing. There is no history of change in decreased mouth opening or loosening of teeth or neck swelling or ulcers anywhere in the oral cavity. And there is no history of referred pain to the ear. Tobacco consumption history. He's a gutka chewer daily, approximately 2 pouches for the past 8 years. And he's been reformed since the time of diagnosis for the past 1 month. He has a history of occasional alcohol consumption. There's no history of dentures or sharp teeth, no history of weight loss, no history of breathing difficulty, cough, bone pain, chest pain. There is no history of any treatment taken elsewhere for the present complaints. There is no significant family history. There is no history of diabetes, hypertension, TB, asthma, or any other medical disorders. So, on summary of my history, my patient is a 34-year-old male, a farmer, a tobacco chewer with a non-healing ulcer over the right lateral border of the tongue, and he is associated with pain and difficulty in chewing and swallowing. So, on proceeding to examination, patient was conscious, cooperative, and oriented. He was average built and nourished. ECOG 0 status. Pulse rate was 86. BP was 116/82. Right arm sitting position. Respiratory rate was 18 per minute. No pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. On local examination inspection, the mouth opening was adequate. It is a dentate patient with poor orodental hygiene and tobacco stained teeth present. So tongue movements restriction was present. There was leukoplakic patches also on the dorsal surface of the tongue. So there was a lesion which is 4.5 cross 4 centimeter lesion over the lateral surface of tongue, anteriorly 1 centimeter from the tip, posteriorly 1 centimeter from CVP, and inferiorly involving the floor of the mouth. So this is the lesion. On palpation, we confirmed the inspectory findings. Medially, the induration was palpated up to midline. Posteriorly, 1 centimeter free from circumvallate papillae. Base of tongue was free. Inferiorly, it was involving the floor of mouth, but it was not abutting the lingual side of mandible. The rest of the oral cavity, no other lesion was seen. Skin is also free. Hopkins showed bilateral cords mobile and no other lesions were seen. On seeing neck, there was no visible swelling, scars, or sinuses. On palpation, there was a right level 2 centimeter hard, tender, mobile node with the overlying skin being normal. The systemic examination was normal. To summarize, my patient is a 35-year-old male, tobacco consumer from Maharashtra with a 4.5 cross 4 centimeter non-healing ulcer over the right lateral surface of tongue involving the floor of mouth abutting midline with reduced tongue mobility with right level 2 node. Most likely it is a malignant neoplasm of right lateral surface of tongue, clinically a T4A N1 disease. Sir,
Anthony, I think investigations and the other will come with the discussion. So let
Okay,
Kiran
sir.
complete her case.
Okay, sir.
Kiran, are you there?
Yeah, I'm there. Let me share this screen. Sir, okay. Good evening, all. I am presenting the case of Mrs. Kanakama, who is 67-year-old female, resident of Alapua, housewife by occupation. She came to us with chief complaint of non-healing ulcer over left side of tongue for past 3 months. As stated by the patient, she was asymptomatic 3 months back when she noticed a small ulcer of peanut size over left side of tongue, which was insidious in onset and gradually progressed to the present size. Patient also gives history of mild dull aching, intermittent pain limited to the lesion site. There is a history of sharp tooth present on left lower jaw, for which she consulted dental doctor and grinding was done 2 months back. Coming to negative history, there is no history of referred otalagia, no history of difficulty in mouth opening, and no history of difficulty in tongue movement. There is no history of difficulty in speaking, swallowing, chewing, no history of bleeding, no history of neck swelling, no history of voice change, cough, weight loss, bone pain. Past history, hypertension is present. Apart from hypertension, no other comorbidity is present or any surgery in the past. Coming to the personal history, patient is having mixed diet, normal appetite, normal sleep, and normal bowel and bladder function. There is no history of any habits. Family history, married with 2 children. There is no history of cancer in the family. Treatment history, grinding of sharp tooth was done 2 months back. To summarize the history, Mrs. Kanakama, 67-year-old female, came to us with non-healing ulcer over left side of tongue, which was insidious in onset and gradually progressed to the present size with history of sharp tooth in the past and without any habit history. Coming to the general examination, patient was conscious, oriented, and coherent at the time of examination. ECOG status 0, moderately built and well nourished. BMI 26.2 kilogram per meter square. Pulse 74 per minute with normal volume and rhythm. Blood pressure 122/84, taken in supine position in right hand, and afebrile. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema was present. This is the local examination picture of the patient. Oral cavity, lips normal, mouth opening interincisor distance 35 mm. Orodental hygiene good. All the teeth were present. On inspection, there was an ulcerative lesion, approximately 1 into 1 centimeter over left lateral border of tongue. And ahead of the ulcer, there was a linear minimal indurated scar at the anterior edge of the ulcer, 6 mm in length. 2 small heterogeneous leukoplakic patch present at inferior edge of the ulcer. So this was the ulcer, and there is 2 linear leukoplakic nodules, and ahead of the ulcer, there was linear scar. Anteriorly, the ulcer was 3.5 centimeter short of tip, posteriorly 1.5 centimeter short of circumvallate papillae, medially 2 centimeter short of midline, laterally floor of mouth was free, well away from lingual gingiva, tongue protrusion was normal. Inspectory findings were confirmed during palpation, and the same ulcer 1 into 1 centimeter was noted over left lateral border of tongue with induration limited to the edge of the lesion. It was tender on palpation. Base of the ulcer was clear with induration present. And rest of the examination, the local examination was the same as of inspectory finding. Rest of the oral cavity was normal. There was no ulcer elsewhere in the oral cavity. Base of tongue soft on palpation. Tonsillolingual sulcus was free. Scopy, oropharynx, larynx normal, and bilateral vocal cord were mobile. On examination of neck inspection, no scar, sinus, dilated vein present, no visible swelling present in the neck. On palpation, no palpable lymph node was present, and carotid pulsation bilateral normally. Systemic examination, cardiovascular system NAD normal, respiratory system also normal, air entry equal on both sides of chest, abdomen soft on palpation, normal bowel sound was present. To summarize the case, Mrs. Kanakama is a 67-year-old female, housewife by occupation, came to us with non-healing ulcer over left side of tongue with insidious onset and gradually progressing, with history of sharp tooth in the past without habit, and 1 into 1 centimeter ulcer was noted on the left lateral border of tongue, away from tip and floor of mouth and midline, without any palpable lymph node. So the diagnosis is malignant ulcer, left lateral border oral tongue. Most probable differential diagnosis is commercial carcinoma, left side of tongue, CT1-NC. Hello.
Yes, Kiran. The examiners can proceed with the questions.
James, your patient, what was the stage you mentioned? Clinical stage?
Sir, it was a T4A N1 disease, sir.
Okay. So in advanced tongue carcinomas, do you have a choice for imaging? Do you have a preference for either CT or MR? Can you tell us what sort of imaging would you do for this patient?
Sir, for this
And
patient,
what's the advantages and disadvantages of CT versus MR?
yes, sir. So for this patient, I would like to do an magnetic resonance imaging, sir. The reason being, I would like to know the exact soft tissue involvement of the tongue, sir, and exact extent of the lesion. And also, I would like to look at the neurovascular bundle involvement in this case. Also, the to what extent the disease is there. And I would like to measure the depth of invasion also, which is better in DOI, which is better in MRI. But the disadvantage being the bone erosion can't be seen accurately. So if I will prefer a MRI for this case. But if I want to see any bone involvement, I will prefer a CT, sir. But for this case, I would like to do an MRI for the above reasons, sir. And to plan my surgical reason and access, I would like to do an MRI, sir.
So obviously your MRI is going to be with contrast, correct?
Yes, sir. Yes, sir.
So what are the additional sequences apart from GAD that you'll ask the radiologist?
Sir, I would like to do a fat suppression imaging, sir. First T1 fat suppression image I will do. And also I would like to do a stir image, because that will give us an idea of the peritumoral edema also. And also diffusion weighted imaging also I would like to do for seeing the nodes, sir.
Anthony,
Yes, sir.
on which sequence is the tongue seen the best? You have asked for 5 sequences. I'm very impressed that you know more radiology than an MD candidate. Tell me on which one is it seen the best?
Yes, sir. So the best it will be seen in a T1 fat suppression imaging, sir.
With or without contrast?
With contrast, sir.
Yeah, so the answer is T1 with contrast. That's the, yeah. So you only need to have a T1 with contrast to see your lesion well.
Yes, sir.
What is this thing about DWI for neck nodes? Is that a common practice?
No, sir. No, sir. Just to see if it is whether it is reactive or malignant. If I have a doubt, I would like to ask for DWI, sir. Otherwise, I will not.
But neck node imaging is basically you want to see the anatomical imaging. If you want to do a functional imaging, obviously you'd go to FDG and things like that. But
Okay,
an MRI will give you the anatomical data that there is a lymph node. Whether it is metastatic or not depends upon the findings of that lymph node, which I'm sure you already know.
Yes, sir.
But I don't think DWI, at least I don't know, I don't think DWI. So you'd prefer an MRI in an advanced tongue carcinoma. Your findings may be that the T1 contrast image, there'll be a heterogeneously enhancing lesion. The advantage of the stir, like you mentioned, it shows the peritumoral edema and the contrast is better in a stir image. In a T1 with contrast, it's not often homogeneous, it's heterogeneous, and also the normal tongue musculature will take up some of the contrast. So you don't have that much delineation as you would do. We have a stir image. And the second thing I'd like to see in the MRI, you said that the floor of mouth is involved.
Yes, sir.
So I would like to see if there is a and you said there's a level 1B node also, is it?
The level 2, sir.
Oh, sorry. Okay. So I would like to see if the sublingual space is obviously involved, whether this patient is a better candidate for a sort of compartment procedure versus just a peroral procedure. So yeah, and obviously CT, the acquisition times are faster, and but CT doesn't give you that much of soft tissue delineation, but it's faster, quicker, and like you mentioned, subtle bone erosions are seen better with CT. Yeah, good.
Yes.
Thank you.
Yes, thank you, sir.
James, in addition to MRI, would you do any other imaging for your case?
Yes, ma'am, I will do, ma'am. Since it's an advanced tongue malignancy, I would like to go for an NCCT thorax also, just to rule out distant metastasis, ma'am. So I would like to do a NCCT thorax in addition to MRI head and neck, ma'am.
Well, I'm going here to go to the operating.
So you said that you'd like to screen the chest for metastasis,
Yes, sir.
correct?
Yes.
So in which group of patients is this highly relevant?
Sir, in advanced tongue malignancies, I would suspect patients might have distant metastasis. And when patients have high nodal burden, sir, when level 3, 4 nodes are there, I will suspect that they might have distant metastasis, sir. And recurrence cases also, I might suspect, sir. So these cases, I will be more vigilant on screening for distant metastasis. This case being a T4A disease, I would prefer an NCCT thorax over a chest X-ray, sir.
Yeah, that is true, but we're not talking only about metastasis, we're talking about second primaries also.
Oh, okay, sir.
Because when you screen the chest, especially if the patient has smoking history, or you don't screen only for metastasis, you want to see if there's a synchronous primary or a second primary in the chest.
Yes.
Can you tell us the features of metastasis versus a second primary on chest imaging?
Sir, I'm not sure, sir.
How will a metastasis look? Is it central? Is it peripheral? Is
Sir,
it single? Is it multiple? Does it have any special shape? Yeah.
Metastasis is usually in the periphery, sir. It appears in
peripheral.
periphery. Yes.
Peripheral, multiple. Yeah.
Multiple, sir. Peripheral,
Yeah.
multiple, and it will be having an irregular shape, sir. Will
it be spiculated? Will it be round? Will it be glass opacities? What sort of thing it will be? Okay, I agree with what you said. Whereas the second primary can be either bronchogenic, or it can, around the bronchus, or
sir.
it can be a de novo adenocarcinoma or SCC of the lung within the lung parenchyma. But you'll have associated mediastinal and hilar lymphadenopathy.
Okay, sir.
So, and the problem is, okay, if you find a second primary, which will take precedence? Will your tongue tumor take precedence in treatment, or will the lung primary take precedence in treatment?
Sir, I'll get an opinion, and I'll first treat the tongue, sir.
So whatever is surgically
James,
treatable.
Surgically resectable, yes, sir. And yes, ma'am.
Richard, go ahead.
Then
Sorry.
let me rephrase this question for you. You have a tongue primary which is operable, but you have a large lung primary. So your tongue surgery is still taking the precedence, or what is helping you decide?
James, you are muted.
Which one is surgically resectable, ma'am? First, I will first go ahead with that, ma'am. In our case,
you have a lung primary, which is advanced and not treatable, and a tongue primary which is excisable. So would you still put your precedence on the tongue primary, or how are you deciding? You get
Which one will affect his overall survival? Which will affect his overall survival more?
The lung primary, sir. Oh,
So
Yeah,
if
so
you're
you
not able to treat one primary, if one primary becomes palliative, the other also you are not going to go aggressive on it. So
yes,
you
ma'am.
will have to gauge it. It is not that you are going to treat the tongue primary always first.
Yes, ma'am. I agree.
Richa and the other, I'll step in here and may not agree with y'all. If the tongue primary is very small, you must go aggressive, and I put my vote on James here. The reason is you want local control from a disease that will increase and affect the quality of life of your patient. But if I have to do a bilateral neck, remove the whole tongue and put a flap in, then I won't do it. So, James, your answer should be, it depends on the stage of the primary, which causes symptoms, which I can treat with least functional and cosmetic problems and rehabilitate the patient quickly. So Komal's case with the T4 tongue, I would operate the tongue, send the patient in 5 days for treatment of the lung cancer,
Okay, sir.
even if it's advanced. I want local control on the tongue and good quality of life.
Okay. Okay, sir.
I would also request to include Kiran in the discussion.
James, would you like to do anything else to assess operability?
Sir, in this case, I would like to do an examination under anesthesia also, sir, so that I will know the exact extent of how much I'm going to resect and what reconstruction I can plan for the patient, sir. So I will do an examination under anesthesia under short GA, and then we will decide the final plan of resection and reconstruction also, sir.
And would it also help you to see for any other second primaries?
Yes, sir. Yes, sir. Yes, sir. It will help me to see for other second primaries also, sir. Yes.
Thank you. So, Kiran, have you done any imaging for your case?
Yes, sir. MRI. Should I share?
Yes. So, like, it's a very small lesion, T1 lesion, as you said, clinically also N0. So, what is the benefit of doing MRI in such a small lesion?
Sir, MRI, we can see if there is a perineural invasion if it is involving the lingual nerve and going along the perineural spread, going along the neural nerve to the floor of, to the submandibular area, that we can see. And
Kiran, I've been seeing MRIs with you, I don't know, for 15 years now. I have never heard the radiologist mention about hypoglossal perineural spread or lingual perineural spread. You will only see a uh, bright signal in the muscle, because those two nerves are not like your facial nerve, or it's not like your trigeminal nerve. It's very difficult to see perineural in that whole muscle chunk. What
Okay.
you might see is the second level and third level, zone 2, zone 3. I've told you the zones of perineural spread. You might see it in zone 2 and zone 3, but per se in the tongue, does it make any difference? Do you? I don't think we are resecting the hypoglossal anyway. I have not seen, or at least I have not been told by the radiologist that this patient specifically has hypoglossal perineural spread, or this patient has specific lingual perineural spread. So I don't think that really matters.
Anyway, I just wanted to ask Kiran a question. You very elegantly said you pinched the lesion and it's pinchable.
yes,
I
sir.
didn't understand why you said that in your history. It kind of fascinated me a bit.
Sir,
Do you pinch tongue lesions, and how do you pinch them, and why do you pinch them?
Sir, to identify the depth of invasion, not depth of invasion, total thickness of the tumor.
How do you do that? If you pinch it, then what happens?
Sir, if it is pinchable easily between the thumb and index finger, it might be less than 10 mm. The lesion depth of invasion or total thickness may be less than 10 mm.
To me, this is something that you should not do because tongue lesions are painful. This is a non-validated uh, clinical thing that you're making us do, and I really don't know the advantage of this pinching of the tongue lesion. I'd ask the other examiners whether they approve of pinching of a tongue lesion and whether Anthony James would pinch tongue lesions.
This was something that Dr. Shah always keeps talking, but like you rightfully said, I don't think you can make a decision on how much you excise or you can quantify the depth of invasion or thickness of the tumor. And like you rightly said, it's very painful. I would do a bimanual palpation of the floor and submandibular if the tumor is extending to the floor of the mouth. But I would never
by digital. I agree
by
with
distal.
this. So, Komal, I'm coming back to you. In a pinchable lesion, how often do you see gross perineural invasion? You answered very elegantly. You want to see it going along the lingual. Forget this boy zone 2 and zone 3. How often is a pinchable lesion associated with gross perineural spread, not perineural invasion?
So in early tongue, the PNI will not be there, sir.
No,
If
it will be there. PNS will not be there. Don't fall for my questions.
okay,
PNI can be there in early tongue. I'll ask you the percentage now. But you said PNS, which is major nerves. Where is a pinchable lesion associated with PNS? You see, y'all all know the theory, but when you answer some unnecessary questions, some nasty examiner like me will tie you into knots.
so sir,
What you are saying is PNS.
so PNS is an imaging finding, and PNI is a histopathological finding. So the perineural invasion, perineural spread, which we see in imaging, could not be there in early tongue, but
Acha, Deepak, you're the internal examiner. Please bail the lady out.
No, you're not understanding sir's question. Is there any position or is there a sir's basic question is like if you're able to pinch the tumor between your fingers, what is the rate of major nerve spread of the tumor? Does it have any correlation or does it make any sense to do that?
there is one paper by Deepa Nayaman, but no,
Sorry?
I don't remember, sir. Sorry. I have to.
Komal, when you get a nasty examiner troubling you, back off from the question. Go to the next question. Otherwise, you'll go deeper into the khadda.
So sorry,
Richa,
I don't remember.
Richa and Apurva may ask some other questions now.
Richa, would you like to ask a question?
Kiran, what is the advantage? So the point is that it's an early lesion, which you are saying is pinchable. So should you be doing MRI in all such cases, or it can be spared in some?
We can spare in some, but the MRI will give us the depth of invasion, I mean the tumor thickness, based on which we can plan the neck dissection.
I strongly disagree with that. There is no imaging that can tell you what is the depth of invasion or tumor thickness. That is, the depth of invasion is a pathological finding. No study has given 100% correlation. The closest that they've come is tongue ultrasound, high frequency tongue ultrasound. But I don't think you should say MRI will give you the depth of invasion so you can plan your treatment. It doesn't carry any meaning like that. And Richard's question is very valid.
Yeah.
Do you do MRI for all superficial lesions?
No, sir, we can avoid in T1, but we can avoid in T1, sir, very superficial.
But you'll still have to evaluate the neck, no? So would you do have a compromise between the two?
So, sir, if you have to measure image the neck also, then we can do MRI, which can give us the detail of the primary as well as of the neck.
Which is more sensitive for neck nodes? Is it MRI or ultrasound? Can you give me the sensitivity and specificity and which study compared ultrasound? It's not a very new study. It's a slightly older study comparing.
There are two meta-analyses by Liao and Debond. So Liao,
Yeah.
The comparison was similar.
The bond is quite old. Liao is better. Yeah, good. Yeah.
So there are two meta-analyses, Liao and Debond. Liao said the comparison for sensitivity and specificity among all CT, MRI, ultrasound, and PET was equal. And Debon said the ultrasound guided FNAC can better predict the neck node metastasis.
Okay,
So,
so what size of lymph node will you ask the radiologist to do an FNAC?
Sir, level 2 more than 1.5 centimeter and rest 1 centimeter, larger in size.
So, Kiran, before we proceed, two questions. You quoted the sensitivity in the Liao meta-analysis and in the DeBont meta-analysis, and we see that there is a difference. Any specific reason that why do we see this difference?
Sorry?
Is the cohort same in the two meta-analysis?
No, ma'am. So there was there were N0 patient in Liao and in Debon there were N0 plus and N1 N plus patient. So the cohort was different in both the meta-analysis.
Correct. So if you have a node negative neck and you're looking for the occult metastasis, none of your imaging is actually helping. In the mixed cohort, of course, it talked about ultrasound and guided FNAC. Would you be routinely doing FNAC for all if you palpate the node? Like you said, 1.5 centimeter. That is a definition of significant lymphadenopathy.
No, ma'am. Because anyhow, we have to do the neck dissection if the depth of invasion, the lesion is T1, T2 onwards. And if the depth of invasion more than 3 mm, though depth of invasion, we won't be able to assess exactly clinically. But if it looks like
She asked you a one-line answer and you're stumbling again. The very clear fact is elective neck dissection improves survival. That's also whether it's a T1 lesion or T2 lesion, 3 millimeter. Sir told very specifically that they weren't powered to study that size. So your answer should be no need of FNAC clinically or radiologically. If the node is positive, you just stage the neck, clinical whatever, but you still proceed to do a elective neck dissection for these patients. That's all.
So
I just asked you the FNAC just to ask you the size. That's all.
So to both candidates, when in early tongue do you do FNAC of the nodes, or when in oral cavity you do FNAC of the nodes? If you're operating all N0s and you're operating the neck in all large Ts, why do you do an FNAC in oral cavity and when do you do it? I don't know meta-analysis, but I only ask practical questions that trouble me in the clinic.
Sir, in cases of carcinoma of unknown primary of head and neck, I might do an FNAC.
Array, my friend Anthony James, I'm saying in oral cavity.
In oral cavity, in oral cavity.
Oh, okay.
It is a early oral tongue lesion with a large node, then we can go for the FNAC to rule out whether it is a metastasis from the oral, oral cancer, or it is lymphoma or TB or something else.
Lovely. How many oral cancers have you seen with coexisting lymphomas?
Sir, very rare.
So you'll do it. So in Amrita, if you have a T1 oral tongue with large nodes, you'll do FNAC of the neck nodes to rule out lymphoma. Internal examiner.
Sorry, we don't do, sir. No. The only place where I do an FNAC of the neck
let
node
her
is
answer, man. Deepak, I don't want you to answer.
Oh, sorry. I thought the question was to Amrita, so I thought you asked
No,
us. Sorry,
I'm
sorry.
just troubling you that you have to take up for your girl. Anthony, answer.
Okay, sir.
Sir, if
Yeah,
it
yes, sir.
is lateral tongue lesion and their neck node on the MRI, the neck node is present on the contralateral side.
So whenever you have a neck node, which is as an unusual site, you will decide to do an FNAC because you are not sure you want to treat it. So don't get into problems about doing an FNAC for the neck node. Tell the examiner with a lot of confidence, sir, I'm operating the neck and I do not want to do an FNAC.
Yes, sir.
Okay, sir. So, James, did you do the examination under anesthesia? Can you describe the findings? Sir, no, sir. I have not done examination under anesthesia for this patient, sir. I'll have to do, sir. Okay. So, how do you decide the reconstruction of the tongue based on the examination under anesthesia? So, in this patient, most probably, when I do examination under anesthesia, I will look into two things, sir. First thing is the base of tongue involvement. So posterior extent, I'll be make sure how much I'm removing, and floor of mouth relation to the mandible, I will try to examine more in detail because patient is having severe pain whenever I examine him, and I will see whether I will be able to get a 1 centimeter margin in the floor of mouth under anesthesia. So, and when I decide the exact final resection plan, most likely my final resection plan, since the lesion is touching up to midline, and it is going into floor of not most likely my surgical plan will be an anterior two-third glossectomy, sir. So for a resection like that, I would like to, with the resources available, I would like to go for a free flap, sir, because
Okay.
I'm saving the full base of tongue. So the tongue mobility can be got, and I would like to put a more pliable flap there. So I would like to put a free flap there, sir.
James, you said you will see in your EUA whether you have a 5 millimeter margin or 1 centimeter margin to the mandible.
Yes, sir.
So if you have 3 millimeters, you will take the mandible?
I'll do a marginal mandibulectomy, sir.
So you want to do a lingual plate mandibulectomy. What sort of marginal mandibulectomy are you talking about?
Sir,
Do you do, I mean, is it practically done like that? I don't know. I'm just asking you. Let's say you have 4 millimeters measured by scale, unstretched mucosa to the mandibular periosteum or the attached gingiva. So if you don't have that, you will do some sort of mandibulectomy, is it? I'm sure you must have seen a lot of cases like that. Do you do a mandibulectomy for all of that? See, a marginal mandibulectomy is for tumors above mylohyoid line, below. That is in a sagittal orientation, how much the tumor has spread.
yes,
That has nothing to do with the surface spread of the tumor. You
Okay.
decide whether you want to do a marginal mandibulectomy, that is the occlusal surface you want to take, based on the sagittal relationship of the tumor with the mandible.
Okay,
But
sir.
we're talking about the mucosal spread along the ventral tongue towards the gingiva, along the floor of mouth.
Yes, sir. Yes, sir.
So, is it a policy to do it like that? I don't think a marginal mandibulectomy is going to treat a tongue tumor that is moving towards the gingiva. That makes no sense. We are
Okay.
talking about the depth in the sagittal plane, how much, and then we decide the mandibulectomy. But
Okay.
I would be more conservative. It's a tongue tumor. I might
Yes.
do periosteal stripping and try to preserve the mandible. Because
Okay.
remember, the combined effect of an anterior two-third glossectomy and a mandibulectomy is severely debilitating to a patient.
Yes, sir. Yes, sir.
So, probably we can be a little bit more conservative there. But
Okay.
you haven't told us the approach. Would you like to do a peroral approach?
Yes, sir. Sir, I would like to do a pull-through approach in this case, sir.
You mean hemi pull-through, half pull-through?
Yes, sir. Half pull-through, sir.
Half
Because
pull-through, because you don't want to damage the floor on the other side. So you want
yes,
to, so that the remaining musculature is still vascular
yes,
and neurotized. Okay. So
yes,
you
sir.
want to do a hemi pull-through. That's good.
Pull-through, sir. Yes.
And the neck, how would you like to address?
Sir, since there is a node in level 2 and it looks suspicious also, I would like to go for a right side, the ipsilateral side. I would like to go for a 1 to 5 neck dissection, sir. And since the lesion is abutting the midline, I would like to go for a contralateral neck dissection also, sir.
Okay, so that is your clinical judgment based on
Yes,
the
sir.
extent of the tumor.
Yes, sir.
Okay.
Yes, sir.
Good, good. So like you said, what are the reconstructive options that you have here?
So, sir, so reconstructive options.
Sorry, James. Before that, I always want to tell you, you have to see the relationship of the sublingual gland and the sublingual space and all that. But
Yes,
since
sir.
you're doing a pull through, you're going to take all the muscles in that side, in that area. So that's fine. I hope you know that there are two recent papers about compartment resection. One was for T1, T2 tumors, and the most recent one 3 months back, both from Italy. The
Yes, sir.
first one we wrote with our data with Peretti's group. The second is a multi-institutional study from Italy itself. So please read about. Don't quote the old compartment. When it started, all that. The newer papers are much more interesting, but there is
Okay.
no difference in T1 to T3 whether you do a compartment or a wide local. In fact,
Okay.
wide local preserves more function because compartment you have to do a hemi resection and then you have to reconstruct anyway. But just please read about the compartment exceptions.
Yes, sir. Yes, sir.
Yeah. So what flap choices do you have?
Yes, sir. So I'll split this as so first the ideal reconstructive option and what we can have available, sir. So for this patient, most probable resection will be an anterior toothed glossectomy. So in this scenario, I'm saving the full base of tongue, sir. So I would like to give him a nice pliable flap. So the reconstructive options first will be a free flap. So if available, I have a good plastic surgeon and I will give for a free flap, sir. If suppose if my resources are restricted and waiting period for plastic surgery is long, then I would like to go for a PMMC, sir. But my ideal reconstructive option for this case will be an free flap, sir, because it will give the pliability as the full base of tongue is preserved. We'll be able to give him a good, comparatively better swallowing outcome when compared to when I do a pedicle flap, sir, like a PMMC.
Yeah, good. Kiran, what would you do after the surgery? What would be your adjuvant plan for this patient? How do you risk stratify such patients?
Sir, it will be based on histopathology report. If it is if so based on Bernier Cooper analysis, if it is if it comes early terms, PT1 or PT20.
No,
So for this time you are talking, no, sir?
we are talking about James's patient.
Okay.
Yeah.
So for James patient case, so if it's a T3, T4, N plus positive margin, presence of ECS, then I will like to subject the patient to the adjuvant treatment in the form of adjuvant RT plus minus chemotherapy in cases of positive margin and ECS.
So for stage 3, stage 4 tumors, you'd want to give adjuvant treatment.
Yes, sir.
For patients who have positive margins and ECS, you'd like to give adjuvant treatment. Please remember that Bernier and Cooper's combined study came in head neck. Okay, so they found common factors, but actual indications for adjuvant treatment were given by Peters and Kianang 3-4 decades ago. That was the risk stratification technique they used for radiation. But the new Bernier and Cooper, which is published in NEJM, was for adjuvant chemo radiation.
Yes, sir.
But adjuvant radiation is a
So
long
Kiran, you talked about
fact thing. Yeah.
Yeah, so you talked about the absolute indication. So if it's a T3, T4, and if it is N plus neck, and you said margin, you said ECS. Are there other factors that you would consider while deciding regarding the adjuvant treatment? Some intermediate risk factors?
Yes, ma'am. So there, so intermediate risk factor, which was given by Kian, and if 2 or more factors are present, then we can go ahead with the adjuvant radiotherapy, like PNI, LVI, presence of PNI, LVI, and depth of invasion more than 10 mm, of course, this T3 onwards, and poorly differentiated carcinoma. Hello.
Did you say the Kianang's paper
No, sir.
was
Kianang and Lister Peter, they suggested to give the adjuvant radiation dose 57 and 63 in cases of adverse factors. So the adverse factor came from Kianang and Lister Peter paper. But
yeah, but the
RS
most
trial is,
important factor in that paper was oral cavity itself was considered a high risk factor.
yes,
They had actually looked for all sites adjuvant treatment, and they found that oral cavity by itself was and they didn't have depth of invasion and all in that paper. That was the concept that only came recently. So
yes.
yeah, so those two papers, they are for adjuvant radiation. But Richard's question is quite, is there any other risk stratification that you use that you know? No, we do that. No, we
Franklin
histopathology. Sorry. Yeah, correct. Yeah, correct.
Scoring, which has lymphocyte response at the tumor advancing edge, PNI and WPOI.
Good. So I know in Tata for PNI they give adjuvant RT. That came from Deepa's paper, but it was a very small number of patients who actually benefited from that RT. Do you know of any other paper which has given a more definitive answer from Australia? What have they done?
Sir,
Did
it
they
hasn't
specifically
been
mention anything about which type of PNI is is benefits from RT, or whether there was any benefit of RT at all from the Australian group?
Yes, sir. Yes, sir. So,
Karina had given it, no?
so sir, extratumoral PNI, I don't remember the finding exactly and the name.
This
So there
from
are
the
two
Sydney
papers.
Ethnic Cancer Institute. Yeah,
So,
just
sir,
read
there are-
that. So if your examiner asks you for PNI, would you give RT or not? You should be able to argue both sides. That's all.
Okay, sir.
James, what are the swallowing rehabilitation exercises that you teach a patient who has undergone a hemiglossectomy?
Okay, sir. So patient undergoes hemiglossectomy. What all maneuvers we can teach him is, sir. First thing we can teach him something called as a Mendelssohn maneuver. Then supraglottic swallow, super supraglottic swallow, chin tuck maneuver. These are the maneuvers and chin tuck.
No, I asked you tongue strengthening exercises. I didn't ask you the techniques for residue
Swallow.
after a normal swallow. Your supraglottic, super supraglottic is you swallow and you cough. Chin tuck is not for oral cavity. It's actually meant for hypopharynx.
Okay.
So and turning your head again to the opposite again is for piriform sinus. Tongue strengthening exercises.
I'll have to read about it, sir.
How do you improve the oral phase of swallowing in these patients? You said the base of tongue is intact, so I don't think he's
Yes.
going to have any problems with his oropharyngeal phase of swallowing or his laryngeal phase of swallowing. So how do you improve his tongue function? And you said you wanted a thin, pliable flap. Is that the answer you should be giving? Because if you give radiation to the patient, that whole flap will get plastered and will be nothing. There'll be no bulk in that flap at all.
And ALT I'll use, sir. So that the
No,
muscle.
any flap is fine, but you just overcorrect it. That's all, to account for the
Okay.
radiation fibrosis. You just have to account for that. That's all.
Okay, sir.
But tongue strengthening exercises, how do you improve the oral phase of swallowing? That is what is important. All the maneuvers that you mentioned are for people who have oropharyngeal disease or
Okay.
people who have hypopharyngeal disease.
Okay. Okay, sir.
To clear the airway and to facilitate opening of the hypopharynx for them to swallow. I'm asking you the oral phase of swallowing. Okay. What else? What else should we ask? Okay, so this patient suddenly has two options: IMRT versus tomotherapy. James?
Yes, sir. I'm here, sir.
Patient is asking you, should I get IMRT or tomotherapy?
Sir, I'll prefer for IMRT, sir, because the adjacent areas will be saved from the radiation effects, sir. So I'll redirect the patient to go for an IMRT, sir.
So you mean in tomotherapy, you don't spare the surrounding structures? You know what tomotherapy is, no?
Yes.
Yeah. So do you know of any comparative studies between IMRT and tomo for adjuvant treatment in post-resection head and neck cancers? What is the advantage of tomo, though? Kiran, do you know?
Yes, sir, tomotherapy is the way of delivering the radiotherapy. It accounts the patient positioning, CT imaging, everything. So the IMRT is part of tomotherapy. I don't remember the study.
No. What is the new tomotherapy? We have a tomo machine in Amrita, right?
Yes.
Did you ever ask them what is the difference from that machine to the conventional IMRT that we are giving?
They told me it is just the way of giving the radiotherapy where they can do the CT imaging simultaneously and the delivery they can precise.
Okay, so both of you go read what the new tomotherapy machines can do, and then tell me or message me what you find out.
Sure, sir. Sure, sir. Yes,
Yeah.
sir. Yes, sir.
Okay, then yeah, Richa, anything you want to specifically ask?
No, in this, I'll just ask, what is the role of proton therapy since we are discussing all about IMRT and tomotherapy? Any role of proton therapy
In tongue cancer, ma'am,
in this case only? Yeah.
uh, IMRT is equally effective. We can spare the parotid more as compared to IMRT.
No. Here in
Just because
proton therapy.
No,
yeah,
sir.
proton and IMRT.
In tongue cancer, no, sir. I haven't come across any study.
Absolutely. Say confidently that there is no role of proton therapy in upfront adjuvant setting in this case. So why are you worried? I just asked you because you were discussing all kinds of adjuvant therapy.
Yes, ma'am.
So James, you have operated the patient, given the adjuvant treatment. How would you like to follow up the patient? Would you like to do any imaging or just clinical examination?
No, sir. So the rate of developing a second primary in oral cavity cancer patients is 4 to 6% per year, sir. So, and it increases. Overall prevalence is also 15 to 25%. So whenever patient comes for follow-up, since being an advanced tumor also, I'll be vigilant in my follow-up. At least during every follow-up, first I will, in the first immediate post-operative, post-radiotherapy period, first 3 months, I will call the patient, sir. At least for the first 2 years. That time, at least I'll get a chest X-ray done and to review the patient thoroughly for any symptoms. So if patient complains of any symptoms, I will get the appropriate imaging done. And I will do a thorough examination of the oral cavity, oropharynx, and Hopkins every time the patient comes for follow-up, sir. And if there is any symptom which patient develops, the appropriate in my imaging, I will do, sir.
So, is there any role of response assessment PET scan after the completion of treatment? Would you like to do it as it was an advanced case?
Yes, sir. We can do, sir. In advanced cases, we have T4 tumors and multiple nodal levels we have done and given CT-RT also. Such cases, I would like to do a screening PET, sir, when patient comes for follow-up. When patient had high nodal burden and the disease was also very advanced, we had done a near total. And such patients, I would like to go for a PET CT, sir. Otherwise, if I have done a hemiglossectomy or anything, I would still prefer to go for a chest X-ray or CT scans. PET CT I will do for advanced primaries.
James,
Yes, ma'am.
my two questions to you. You are continuously talking about the second primary, you talked about the incidence, you talked about the cumulative incidence. And for the second primary, you are saying chest X-ray. So my two questions. One, what is the commonest site of the second primary in the oral cavity? Second question, how sensitive is X-ray in picking up the second primary if it is in the lung?
Most common site of second primary is tongue.
What is the commonest site of the second primary in the oral cavity? It is the oral cavity.
Oral cavity. Oral cavity. Yes, ma'am.
Oral cavity, second primary commonest site is oral cavity.
Oral cavity.
So
yes,
what is the advantage of the X-ray? So probably you are implying lung second primary. Then my second question to you is, how sensitive is chest X-ray in picking up the second primary in the lung? And then my third question to you is, you said that if you had a disease which was locally very advanced, large nodal burdens and all and everything, in that case, you would think of following up this patient with a PET scan. Suppose you pick up a thing on the PET scan, is there a cure that you can offer to this patient? So is PET really beneficial in this patient, or a cohort where you can salvage in time? So maybe T1 and T2s and T3s and not exactly the T4 and N3Bs that you're talking about. So where is the benefit of doing a PET scan?
Yes. Yes.
Richa's question and answer is very, very valid. The reason being, all of this PET scan drama came in patients who are treated with organ preservation and patients who likely need surgical salvage if the organ preservation fails. And like she rightly pointed out, if you have a discrete lesion that can be clinically seen in the oral cavity, why, and if the patient is symptomatic, why would you have a routine PET scan like that? So we don't follow that. I don't think there's any strong evidence to state that that you should do a follow-up scan for a patient that has been operated. I would do it for patients who had T4 buccal mucosas, patients who had ITF involvement, patients who had clinical perineural spread or whatever. Those patients, I might repeat a PET scan after some time, but I generally don't. And the problem with the chest X-ray is that unless the nodule is more than 2 centimeters away from the ribs, away from the bronchial markings, you cannot make out, second primary in the lung. It's very difficult to make out. Or there's gross rib erosion or things like that, or a collapse from the lumen being occluded. It's very difficult to see it on the chest X-ray.
Okay, sir.
My next question to you is, you talked about the frequency of the follow-up, which you said 3 monthly. So what are your goals at the follow-up? And apart from the clinical examination, what other things are you going to look after when the patient comes to you?
So first, when the patient comes to me on follow-up, ma'am, first I will see a general examination, ma'am, complete examination of oral cavity, oropharynx. I'll do an Hopkins also. Second thing is, I'll see if patient has received RT. So if patient has been received RT, I would like to get a thyroid function test done to assess his thyroid levels also. Other than that, I would also see if he's, I will monitor his speech and swallowing ability. For our patients specifically, these patients have a tendency to be prolonged Riles tube access. So I'll make sure that they, as early as possible, I will make them start orals. And are they taking nutrition adequately? If not, find out the reason and refer them to a dietitian and give them the appropriate diet for the patient. And also, I will, since we have done bilateral neck for the patient, I would give an aggressive physiotherapy. So at every follow-up, I'll send the patient to a physiotherapist also, and teach them the exercises and encourage them to do it daily. And also appropriate follow-up with the radiotherapist and the chemo person also, and repeat investigations also I'll send to see if all HB and everything is within normal limits, ma'am.
James, as it is going to be a major resection of tongue, do you offer option of PEG to the patient, intraoperative PEG, or you only offer them Riles tube feeding?
Sir, this resection being an anterior 2/3 and I'm preserving the full base of tongue, I will still prefer the patient to have Riles tube and start orals appropriately, sir. If it was a TG or NTG I'm talking about, I will definitely give the patient option of an intraoperative PEG, sir, because the feeding tube dependency will be more in such patients, sir.
Okay, and what is your indication for doing tracheostomies in such patients? Would you always do a tracheostomy in a free flap, or depends on the resection? How do you decide that?
There are intubation causes of tracheostomy and extubation causes. So intubation causes is if the lesion is very posteriorly located, sir, and it is blocking the view of the airway, and if flexible bronchoscope is not available in that setup, in such cases, I would like to do a tracheostomy. Extubation causes being in cases where we do NTG or TG, sir, the genioglossus muscle is cut, sir. So the chances of the tongue falling back is more, sir. So in such cases, I would like to do a tracheostomy. And and as a principle, any lesion which we are cutting the tips or crossing the midline, those cases we will do a tracheostomy, sir. So that to prevent, and in cases like NTG and TG, the chances of aspiration are there. Those cases we will definitely do a tracheostomy.
Good.
Kiran, what is the role of frozen section during resection of these large tumors? And what would you do if you find dysplasia at your margins in the final histopathology?
Sir, role of frozen section in large tumor resection to see the mucosal margin and to see the deep margin. If it is less than 5 mm, then we have to revise. But on a contrary part,
how do you know it's less than 5 mm unless it goes to pathology? You measure it, that's what you're saying.
Frozen section. you said.
Yeah, in frozen section, they'll tell you the margin is positive or negative, that's all. How do you know the distance?
Yes, sir.
Do you do patient side frozen or specimen side frozen? Which is
So,
better?
sir, specimen, it is always a specimen-driven frozen.
Good. And if you find dysplasia at your margins in the final list of pathology, what would you do?
So if there is carcinoma in situ, severe dysplasia and moderate dysplasia, we will revise the margin, sir, 5 mm.
But you've already put a flap, you don't know where the susceptible margin is.
Yes,
Practically, is it possible? Do we do that practically in our situation?
Sorry, sir, I could not get it. The
No,
last.
we've already put a flap and patient has, how do you mark that area where the dysplasia? They'll say posterior margin, but posterior margin is a very wide margin. So, is it a practical thing that is possible?
If it is not possible to revise the margin, then maybe the role of adjuvant RT. In such cases, if severe dysplasia they report or carcinoma in situ they report. If it is possible to revise the margin, then obviously I'll go for the revision of the margin. If it is not possible, then role of adjuvant RT.
Adjuvant chemo RT, you mean?
So in cases, yes, a positive margin, then chemo RT.
Yes. James, what do you do in Tata when you find a dysplasia at the margins?
Sir, this is in post-operative biopsy report you're saying, sir? Or
Yes, post-operative.
Sir, we will two options we can think of, sir. One is margin revision, or we can send a patient for adjuvant treatment.
Okay, so your posterior margin has come positive in the vallicular. Your next margin is going to be laryngectomy.
We'll go for CTRT and we'll inform the patient regarding the guarded prognosis also, sir, in such cases.
James, does it matter whether it is a mild, moderate, or severe dysplasia, or it's a carcinoma in situ, or you are going to follow the same policy in all?
Ma'am, yes, ma'am, same policy, ma'am. We'll follow the same policy.
So if there is a mild dysplasia at the margin and you get a margin, say about 3 millimeter and mild dysplasia, you are going to subject this patient to radiotherapy. If you can't revise the margin.
Yes.
Okay. James, do you know any study that has compared nasogastric feeding with PEG feeding for oral cavity post-op?
No, sir, I'm not read about it. I'll read, sir. I'll read
Kiran,
about
do you know?
No, sir. I'll read, sir.
So there's a comment on the chat box that R1 to R0 has similar prognosis. So I'd like to make it clear that whenever there is a margin that is positive on table or it has come on frozen section, margin revision definitely has a benefit. So we should not say that if there is no benefit, so we should not revise the margin at all. So not revising the margin will be more harmful.
Of course, very true. But if you do a total mastectomy and then you don't know where the margins are positive, then you think of other things. But when you can revise it, as Azim said rightly, you have to revise it.
Okay.
I would request the examiners to maybe wind off the session now.
Yeah, I think we can.
So I would like to just
very well done to both James and Kiran. Very well done.
Yeah, good job.
Wishing you both the very best for whenever your exams come up.
Thank you, sir.
So thank you everyone for joining. Dr. Anil Tikru sir has to leave because of the surgery. So thank you Anil sir for joining. Thank you Dr. Deepak, Dr. Apoor and Dr. Richa. And I thank all the participants. We'll be coming once again after 2 weeks with a new session and a new topic. And we'll ensure that you all enjoy the topic like this. Thanks a lot. Thank you everyone.
Thank you, sir.
Thank you, Asim.
Yeah. Thanks, Asim. Yeah. Bye-bye.
Bye-bye.